This recording is going to go over albuterol and the nursing process box for adrenergic agonists. So while epinephrine was a non-selective medication that worked on multiple receptor sites, albuterol is selective. It acts on beta-2 adrenergic receptors, and it's a beta-2 adrenergic agonist. So with an adrenergic agonist, and this one's specific to beta-2, but an adrenergic agonist, we're going to see what response in the body, a sympathetic response or a parasympathetic response. An adrenergic, you think adrenaline, you think sympathetic, fight or flight. With an adrenergic agonist, we're going to see that sympathetic response. Now, albuterol is selective on the beta-2 receptors, and it promotes bronchodilation. So it's used for many respiratory disorders, notably asthma, COPD, bronchitis, bronchospasm. So since it's selective, there's fewer undesired adverse effects and side effects from the medication. If it's being prescribed to treat a respiratory disorder, it's beneficial that it's selective to the beta-2 adrenergic receptors because beta-2, right, works on the lungs, so you're going to have less undesirable like cardiac side effects by the beta-1 receptor being involved. However, high doses of albuterol may affect beta-1 receptors, causing increase in heart rate. Albuterol should be used with caution in patients with severe cardiac disease, hypertension, hyperthyroidism, diabetes, patients who are pregnant, as well as patients with renal dysfunction. And again, you recognize that word renal meaning what? Hopefully you're thinking kidneys. Some side effects and adverse reactions that you might see again when you're talking about an adrenergic agonist, they seem to make sense. Tremors, nervousness, restlessness. The tremors is a frequent thing, especially if a patient who's not used to albuterol and they're getting an inhaled nebulizer treatment and they start experiencing some tremors, and they might say, I don't know why I'm shaking like this, because they're not used to taking albuterol and don't know that that's a side effect of that. Other side effects, adverse reactions include dizziness, tachycardia, palpitations, and dysrhythmias. In regards to drug interactions, we may see increased effects of the albuterol if taken with other adrenergic agonists, as well as MAOIs and TCAs. Beta blockers may inhibit the action of albuterol. So go ahead and pause the video and review the nursing process box for adrenergic agonists, and then go ahead and resume the recording. So in terms of assessment, we want some baseline numbers, vital signs, glucose. We want to get a medical history and a drug history from the patient. In regards to planning, what do we want to see in our patient who's taking these adrenergic agonists? We want their vital signs to be within acceptable ranges, and the patient will experience therapeutic effects by improved BP, breathing pattern, and cardiac output. In terms of nursing interventions, you want to monitor the IV site frequently when administering norepinephrine, dopamine, and epinephrine, because extravasation of these drugs causes tissue damage and necrosis within 12 hours. The antidote, if you do have extravasation, would be phentolamine mesylate. Let me put it up there, phentolamine mesylate. So the antidote for extravasation of epinephrine, norepinephrine, or dopamine. We want to monitor the patient's vital sign. We're going to be watching for increasing blood pressure and heart rate. We want to make sure that the patient doesn't start experiencing severe hypertension. We want to monitor the ECG for dysrhythmias when adrenergic agonists are given IV. We want to report any side effects such as tachycardia, palpitations, tremors, dizziness, and increased blood pressure. We want to check for urinary output and assess for bladder distension. Urinary retention can result from a high drug dose or continuous use of adrenergic agonists. So this goes back to understanding that sympathetic nervous system. I'm talking about adrenergic agonists. I know adrenergic adrenaline, sympathetic, fight or flight. And I know in terms of urination, when I have that fight or flight engaged, that I'm not going to stop and take a bathroom break during fight or flight. So if with those patients who are going to have the sympathetic nervous system response, a problem that we're going to watch for is urinary retention. We want to evaluate blood glucose levels in patients with diabetes for potential elevation, right? Engaging that sympathetic nervous system, increased blood glucose could be a response that we see. In regards to patient teaching, We want to advise the patient to read labels of all over-the-counter drugs for cold symptoms and diet pills. Many of these have properties of sympathetic drugs and should not be taken if the patient is hypertensive or has diabetes, cardiac dysrhythmia, or coronary artery disease. You do not need to worry about the information regarding nasal sprays. We will talk about those when we talk about upper respiratory medications. You do need to, under self-administration, review the information regarding the EpiPen. So encourage the patient to have an EpiPen readily available at all times and to store additional medication in a cool, dark place. Refrigeration is not recommended. Teach the patient and family that the EpiPen must be used immediately upon initial occurrence of difficulty breathing, wheezing, hoarseness, hives, itching, or swelling of the lips or tongue. So all those symptoms that I just said are symptoms of an allergic reaction, and the EpiPen is used to treat that. Teach the patient to administer the EpiPen properly. Inspect the solution for particles or discoloration prior to administration. Don't use if any of those are seen. We want to inject it sub-Q. Want to make sure that they apply sufficient pressure to activate the EpiPen while holding the device in place for 5 to 10 seconds. The EpiPen should be inserted into the outer thigh. After administration, the patient should massage the injection site for 10 seconds to promote absorption and reduce vasoconstriction and tissue irritation. It is important to teach the patient that if they've used their EpiPen, they then have to go to the ER to be evaluated. So we don't want someone treating an allergic reaction with their EpiPen and thinking they're fine, because when the Epi wears off, they might resume that allergic reaction. So we want them to be checked out in the ER. We want to encourage the patient to report any side effects to the provider, such as rapid heart rate, palpitation, rash, itching, irregular heart rate, vomiting, numbness of fingers or toes, because the provider may need to adjust the dose. In terms of evaluation, we just want to evaluate that the medication is doing what it's supposed to do. We want to evaluate vital signs and report any abnormal findings. So if I had an allergic reaction and I used epinephrine, are the signs and symptoms of my allergic reaction going away? Are the hives going away? Is my wheezing decreasing? Things of that sort. If I use albuterol to treat my asthma, well, after I give myself the albuterol, do my symptoms start improving? Does my wheezing decrease? Can I breathe better? Does my SpO2 increase?